Welcome back, and let's talk about the blood supply of the heart. Now, what is unique about the blood supply of the heart? Its lack of anastomosis. And what does this mean? This means that branches of the coronary arteries, which are the main blood supply to the heart, the coronary arteries, are generally considered to be functional end arteries. This means that these arteries are lacking sufficient anastomosis. And what does this mean? If you see other organs, you would see numerous of arteries, and these arteries coming around certain areas of the organ, and they would supply. So if occlusion to happen in one area, another blood supply would come and take over. Uh, in a term, we call it anastomosis, especially around shoulder joints, the joints, and in many different organs, internal organs in our body. Unfortunately, this is not the case in the heart. It seems that anastomosis are not well developed in the heart, although some anastomosis do exist. And as we proceed, I would highlight this. You may ask why it is matter the anastomose. Simply because if you do have anastomose, it means it means that if occlusion to take place, another source of blood supply can take over and supply the affected area. But more on that, of course, in the next upcoming slides. Two arteries, the right and left coronary arteries, are the main blood supply to the heart. It's always interesting to know which one, in terms of the size, bigger, and of course we would talk about these two arteries in details as we proceed. The caliber of the coronary arteries, both main stem and larger branches, it means both stem in regard to the right coronary and left coronary arteries, and their branches, based on measurements of arterial cast or angiograms, ranges between 1.5 and 5.5 millimeter for the coronary arteries at their origin. The left exceed the right in 60% of hearts, the right being larger in 70% only, and both vessels being approximately equal in 23. So what we can conclude from this, that the left coronary artery is in 60% of people. It is larger than the right, but the right also can be larger in 17% of people, and both of them equal in 23% of population. And we may reflect on this 60% the left. Why is that? We need to answer this as we exploring the blood supply of the heart. The diameters of the coronary arteries may increase up to 30th year of the life of an individual, which is something to be discussed in the clinical application on the coronary arteries and infarction in young people. Now, the blood supply, as I mentioned, coming from of course, two coronary arteries. The two arteries, as indicated by their name, form an oblique inverted crown in which an anastomotic circle in the atrioventricular groove is connected by marginal and interventricular descending loops intersecting at the cardiac apex. Now you just said that anastomosis between the arteries of the heart are not common. And now in this slide you just saying that the coronary arteries, they form anastomosis. Yes, this is exactly what I mean. Now this is the right coronary artery. Look, this coronary artery descends down, and the left one immediately divides into the circumflex and the anterior interventricular, or the, of course, LAD. We will talk about this just in a moment. Now if you look under the artery, you would see here this is a circle going this way, and the coronary artery on the other hand, here the right one, going in the same path. So the main arteries, the coronary arteries, they make a circle around the heart, and this is the best way to reach the heart, to make a circle. And from this circle, these arteries also approaching each other in most cases, and this is the way the heart supplies itself, by means of circle and communication between the different arteries of this circle. But not all of them can reach other arteries. For example, look at this one. This is has no anastomosis with others. This one, other ones. But some of them, like this one, in most cases they have anastomosis with a nearby artery. The left coronary artery, the right coronary artery, the endocardium, and so we agreed upon that, two coronary arteries. Now, are they the only blood supply to the heart? Now let's read this. The endocardium and some subendocardial tissue located immediately external to the endocardium receive oxygen and nutrients by diffusion or microvasculature directly from the chambers of the heart. So the endocardium, which is a very thin layer of endothelium lining the heart, and the subendothelial tissue, subendocardial tissue, can by diffusion get their blood supply from the blood within the chambers. So obviously that the coronary arteries are not the only blood supply, but they are the main blood supply to the heart. Now I think this slide has been explained to you in the last lecture. This is the ascending aorta. It has the aortic valve. Within the aortic valve we have three cusps. During embryogenesis they were right and left posterior one, then they would rotate, and we will talk about this in development of this artery. But for now we have from the last lecture we've agreed upon three cusps: the posterior and sinuses, of course, posterior, right and left. So the left coronary artery originates from the left sinus, and the right coronary artery originates from the right coronary sinus, leaving the posterior without any arteries, and therefore we call it the non-coronary cusp. It means that no coronary arteries originating from this cusp. So again, the aortic, the ascending aorta has been cut through, and you can easily see that the right coronary artery takes its origin from this area in the right aortic sinus, while the left from the left aortic sinus, leaving the posterior without the any coronary arteries. Therefore, when we talk about the origin of the coronary arteries, you have to state that the left originates from the left coronary sinus, aortic coronary or aortic sinus, and of course the right is originating from the right aortic sinus. And let's now talk about each one of them. So what you really need to know from the former 3 or 4 slides, I'm not sure, that variability and anastomosis within the myocardium is huge. We need to talk about it in details. Common origin for the coronary arteries, it's from the ascending aorta, from the right and left coronary aortic sinuses correspondingly, as we mentioned them just in minutes ago. Okay, now let's talk in details about the left coronary artery. Originates from the left sinus of Valsalva, the left aortic sinus, we just mentioned that, of the ascending aorta. Then it passes between the left auricle here. This is the left auricle, and this is the pulmonary trunk. In fact, I would demonstrate this to you during our next week practical sessions. I would show you when we reflect the auricle and we would find the artery running between the auricle and the pulmonary trunk. So this is what we were just about to mention. Between, we mean the left coronary artery passes between the left auricle and the left side of the pulmonary trunk. You need to understand that the left coronary artery is very short and it immediately divides, and therefore you shouldn't be surprised from the fact that the usual length for this artery is 0.5 up to 2 centimeters. It depends upon where it would divide, but it is ultimately a very short artery if you compare it with the right coronary artery. Look, here is the left coronary artery, very short artery. However, if you look, this is the coronary artery. It branches as it descends down, 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 but it never divides until it reaches the final target, and there it becomes the posterior interventricular artery. So first of all, the left and right, they are different in terms of their length. The left coronary artery is the shorter, is the short one. Now travels a short course between the left auricle and ventricle and divides into 2 branches. Instead of ventricle here, I would rather put it, as we mentioned, between the left auricle and the left side of the pulmonary trunk, into 2 branches, anterior interventricular or left anterior descending artery, and this is the common name that you would hear during your training in any hospital, and the circumflex artery. So what does this mean? As you can see, the left coronary artery divides immediately into left circumflex artery, and of course here the anterior interventricular, or the more common name, the left anterior descending LAD, left anterior descending artery. Now sometimes, as you can see, this is the anterior interventricular artery. It gives off a branch, diagonal branch of anterior interventricular artery. Now what this box is stating, that sometimes the left diagonal artery, which is this one here, can immediately originate as a third branch from the left. But commonly it is a branch from the anterior interventricular artery. So you may find three branches: the anterior interventricular or LAD, the left circumflex artery, and sometimes you may find the left diagonal artery. But if it's not originating from the left artery, then it is as it is here, normally originating from the anterior interventricular artery. Now, what are the branches of the left coronary artery? The anterior interventricular or left anterior descending, we call it LAD. Let's talk about this very important artery. It runs downward in the anterior interventricular groove to the apex of the heart. In most individuals, it then passes around the apex here down, and as we mentioned here, as you can see, branches. This is the whole picture here, posterior view. This artery coming here, this is the terminal end of the anterior interventricular artery, LAD, that in many cases it approaches this artery, the posterior interventricular artery, and they anastomose. So the LAD usually reaches the apex and it goes downward towards the pad, the posterior interventricular artery. Now, in 1/3 of individuals, it ends at the apex of the heart. Now, in 2/3, as statistics indicate, the anterior interventricular artery or the LAD terminates somewhere here in the apex. What does this mean? It means in some people, in fact in 1/3 of population, the LAD may terminate without anastomosing with the anterior posterior interventricular artery. Is it good? Is it bad? Usually it's much better to have an anastomose between these two arteries. However, this does not mean anything wrong with the heart if there is no anastomosis. Maybe other anastomoses would be in this area or that area that may replace this anastomose. Now, the LAD is the most common artery to be affected. In myocardial infarction, the left anterior descending artery is obstructed in 50% of cases, comparing to the right coronary in 30% and the circumflex artery in 20 of the cases. So the most common artery, it's not the left coronary artery, it's rather its branch, the LAD, okay, and then the right coronary artery itself, and after them, of course, the circumflex artery. So put all this together, if the left coronary artery is not common to be obstructed, but obviously it's two branches, one of them occupying 50% of all cases. The left circumflex takes almost 20%, so leaving around 30 for the right coronary. So if you hear about myocardial infarction, according to the statistics, you should think about the left coronary artery branches. The first one to think about, it's the LAD. The second one is the left circumflex, and the third option here is the right coronary artery. This is how you should think about these arteries and their occlusion. Now, it is very important for you to understand that as doctors, we do ECG for patients with complaining about myocardial infarction, and therefore it's very important for us doctors to recognize the area that has been affected. This is good for the evaluation and prognosis and treatment of the patient. We do know from ECG which part of the heart is struggling, and therefore we need to know the contribution of the left coronary artery towards the myocardium of the heart. Which part of the myocardium has been affected using the ECG and other tests to just identify what's going on in the heart. And therefore we need to know that the left coronary artery supplies the anterior of the left ventricle wall, anterior 2/3 of the interventricular septum, so almost all the heart, the left part of the heart, plus bundle of Hess, apex of the heart. The LAD is the most common site, we did mention that. So let me summarize this to you. The left ventricle and of course the left atrium, it's not written maybe here, also are supplied by the left coronary artery, and there is a contribution towards the bundle of Hess, though this could be variable. We will talk about it just in a moment. Now the circumflex artery, it is the same size as the anterior interventricular, so the left coronary artery divides into two almost equal size arteries, the LAD and the the circumflex artery, So it is the same size as the anterior interventricular artery. It winds around the left margin of the heart in the atrioventricular groove. So this is very important. The LAD was running in the anterior interventricular sulcus, while the circumflex artery, this would run in the coronary sulcus. Again, some of you may think that the left coronary artery has been given this name, coronary, to run in the coronary sulcus. No, this is not to happen. What happens in fact that the circumflex artery passes around the right in the sulcus, while the anterior interventricular runs in the anterior interventricular sulcus, and the left coronary artery is just running between the auricle and the left side of the pulmonary, leaving its branch to run in the coronary sulcus. As the artery descends and winds around the margins of the heart, it gives off branches: a left marginal artery, anterior ventricular, such as all these anterior ventricular, atrial branches, it gives it to the atria, and of course all these arteries may anastomose between each other and nearby structure, and they may not even do so. These are the different branches of the arteries. Here, summary of the overall arterial supply to the heart from the left coronary artery. Now, the left coronary artery supplies most of the left ventricle, a small area of the right ventricle to the right of the interventricular groove, the anterior 2/3 of the interventricular or ventricular septum, most of the left atrium. So you need to memorize that the left and left atrium and ventricle are supplied by the left coronary artery, and they contribute at, of course, the anterior two-thirds of the ventricular septum, interventricular septum. So this is by all means the left chambers of the heart are supplied by ultimately the left coronary artery and its, of course, branches, and it even supplies the right bundle branch and the left bundle branch. Both of these bundle branches are supported and supplied by the left coronary artery. Interesting. Now let's talk about the coronary artery. Arises from the right anterior sinus of Valsalva. We talked about this. Runs along the right atrioventricular sulcus, which is the coronary sulcus, and has a different name, embedded in fat. If you compare this artery to this artery, the right coronary artery is running in this sulcus, the coronary sulcus, or the atrioventricular sulcus. But the left coronary artery, it runs for a small distance between the auricle and the left side of the pulmonary artery, and then its circumflex branch that runs in the atrioventricular groove. Branches of the right coronary include the following: sinoatrial, SA node, AV node, atrioventricular nodal artery. It arises from the distal end of the right coronary artery as it forms the posterior interventricular artery and penetrates the interatrial septum to supply the AV node. Posterior interventricular artery, we will talk about this as we proceed. So now I can tell you that it seems to me that the left coronary artery is the artery responsible for the blood supply of the left ventricle and the anterior two-thirds of the interventricular septum, plus almost the left auricle, so plus the apex of the heart, and put all this together, and bearing in our minds that the left ventricle is almost 3 times bigger, the wall, the thickness of the wall of the myocardium, and the left ventricle is larger than that of the right atrium. And of course, considering the interventricular septum as part of the left ventricle, as it is in thickness equal to that of the left ventricle, one can assume that the left coronary artery is almost responsible for the blood supply of the left chambers of the heart. It is the main artery to supply the pump of the heart that pumps the blood to the whole body, and that's why its branches of the left coronary artery are to be affected more than those of the right coronary artery. This is what statistics tell us. Now, what is the overall contribution of the right coronary? Now, if we go here, SA node, AV node, of course, and the posterior interventricular artery, plus the right ventricle, right atrium, of course. But one can assume that the right coronary artery is more engaged not only in the myocardium but also in the conducting system, the SA node and the AV node, and this is something we need to talk about it. The occlusion in the right coronary artery may result in damage to the AV node, especially, and this may cause huge damage to the heart. So, what I would like you to take out of the blood supply from the coronary artery is that the left is the larger one. The left is responsible for the main pump of the heart, which is the left ventricle. The left is the one that usually get affected more than the right. No, on the other hand, the right is engaged in the blood supply of the conducting system. More on that as we proceed. Now, arterial supply to the conducting system. This is very interesting. The SA node is usually supplied by the right, but sometimes by the left coronary artery. From the right coronary artery near its origin in 60%, and this is something we need to appreciate. The SA node is in 60% from the right coronary, leaving 40% from the circumflex branch, not from the left coronary, but from its circumflex branch of the left coronary artery in 40%. And this means that if this is the case in 40% of population, this means that the artery originating from the circumflex artery has to travel a long distance to reach the area of course, the SA node. And that's why, as you can see in this diagram here, it is the artery that would cross over this area here and to reach the target area, the SA node near to the superior vena cava in the right atrium, of course. And this sometimes cardiac surgeons, they may operate on this area, and they sometimes cut through this artery, causing damage to the blood supply of the SA node, and that's why this approach is not the best approach, but sometimes they are forced to go into such procedures, of course. Now, how about the AV node and the atrioventricular bundle? They are also supplied by the right coronary artery. So the SA node is 60% from the right and 40% from the left. The AV node seems to be from the right coronary artery. More on this just in a moment. The right bundle branch of the atrioventricular bundle is supplied by the left coronary artery, and of course the left bundle branch is supplied by the right and left coronary artery. So this is the blood supply to the conducting system. Now here we would talk about variation, normal variation, and I would reflect on the AV node blood supply and its importance as we discuss this slide. Now the variation here, it's all about the posterior interventricular artery. In 90% of population, it is a branch from the right coronary artery. As it descends in the coronary sulcus, giving these branches, then it turns down on the diaphragmatic surface, and it gives off the left coronary artery as it is here. This is what we call right dominance. In 90% this is the case. The posterior interventricular artery is a branch from the right coronary artery. Now in 10% of population, as you can see in this diagram, the left coronary artery, the circumflex artery, continues in the sulcus, coronary sulcus, and then it gives the posterior interventricular artery, and we call this left dominance. It is only in 10% of population. So 90 and 10. To be honest, some other statisticians or in other studies, they make it 90, 80 and 80 right dominance, 10 left dominance, and 10 this third pattern where from the left coronary there is a posterior interventricular artery, and from the right coronary there is also another posterior interventricular artery, two arteries coming from different coronary arteries, and they call it balanced. So both arteries, they contribute to the formation of the posterior interventricular arteries, and this is not common. So there you go. The most common is the right coronary artery supplying the posterior interventricular artery, then left dominance, where the left coronary artery supplying the or giving off the posterior interventricular artery, and then sometimes two posterior interventricular arteries are existed, one from the left coronary and the other one from the right coronary, and they call it balanced pattern of blood supply. Now, the term dominant is used to refer to the coronary artery giving off the posterior interventricular descending branch, but also I have to highlight this box. The term dominant is misleading because although in 10% of people the left coronary may only in 10% of people the posterior interventricular artery may arise from the left coronary, that does not mean that the left coronary artery is less important. Still, the left coronary artery, as I mentioned to you, it is the larger artery. It supplies the more myocardium than the right coronary artery. Because the left artery almost always supplies a greater volume of tissue than the right. It's not only this. Why there is so much debate about the origin of the posterior interventricular artery? I have to explain this to you. So in this case here, in 90% of people, the posterior interventricular is originating from the right coronary. This means that the right coronary artery is responsible for the blood supply of AV node, as we mentioned here. The AV node, okay, it's a branch from the right coronary artery, bearing in our mind that in 90% of population, the right coronary artery gives off the posterior interventricular, and this artery supplies the AV node, and therefore in this case here, if the posterior interventricular coming from the left from the circumflex, it means that the left coronary artery here is supplying the of course the AV node, and in these people, if the circumflex gets blocked or occluded, it means that in these people the AV node would also suffer. So clinicians, they like to put it this way: dominance, it's when it's all about who would supply the AV node. Usually it's the right, but in sometimes it is the left, and therefore there is a debate about the word dominance in terms of only to simplify it with which one gives the posterior interventricular artery. It's rather all about the AV node blood supply. As you may know from your course of physiology, any block in the AP node would have a great influence on the pumping activity of the heart, and it may lead to complications that may ended up in death. Now, because still the myocardial infarction stated as among the most common cause of mortality and morbidity, yet could be the first place the cardiovascular diseases leading to death. That's why you would see more and more everyday research coming about the blood supply to the heart as the main cause of death. And that's why scientists they've been looking for sources of blood supply apart from the coronary arteries, and they found that there are also intra and intercoronary anastomosis in vessels. The most frequent sites of extramural anastomosis are the apex anterior aspect of the right ventricle, posterior aspect of the left ventricle, interarterial and interventricular grooves between these, and these areas are they have anastomosis. Also, the functional value of such anastomosis must vary, but they appear to become more effective in slowly progressive pathological conditions of the heart. So these are within the heart itself. Extracardiac anastomosis as an answer to it's only the coronary arteries that supply the heart, or maybe there are other arteries. Many connect various coronary branches with other thoracic vessels via the pericardial arteries and arterial vasa vasorum, and you may ask of course about the systematic and pulmonary circulation. The effectiveness of this connection as collateral routes in coronary occlusion is unpredictable. So we can't deny the fact that they are there, but we don't know if their existence can prevent occlusion or may give the patient more anastomosis, more blood, and he would escape and survive occlusion. Coronary arteriovenous anastomosis and numerous connection between the coronary circulation and the cardiac cavity, producing so-called myocardial sinusoid and atrioluminal vessels also been reported. So the whole slide is read only, but here I just need you to highlight the fact that the blood supply of the heart is one of the major, if it's not the number one killing cause leading to death and morbidity for us as a human beings. And therefore every piece of information about this the blood supply of the heart should be considered because of its clinical value. Now the venous drainage here is interesting because you may think that if I have anterior interventricular artery, I would have anterior interventricular vein and etc. In fact, as a muscle, the heart, don't you ever forget it's a muscular pump. It does not follow this pattern as in other organs of the body, and therefore you have to be careful when we mention the coronary arteries. They are not usually accompanied by the same veins that carry the same names. For example, the great cardiac vein lies in the anterior interventricular sulcus with LAD. So they are different in names, middle cardiac vein, of course, in the posterior interventricular sulcus with the posterior interventricular artery. So the great in the anterior, the middle in the posterior sulci, both accompanying by arteries that different from their name, and of course the both they open into what we call the coronary sinus. This is the coronary sinus. It's on the posterior side of the heart. Here it's on the posterior right side of the heart. This is the middle cardiac on the posterior or on the diaphragmatic surface. The great cardiac in the running in the anterior interventricular sulcus, and they all open in the coronary sinus, of course. There are vena cordis minimi, Thebesian veins, and anterior cardiac veins. These veins open directly to the chambers of the heart, of course. The venous drainage of the heart, most blood from the heart wall drains into the right atrium through the coronary sinus. We did mention that, and the coronary sinus, of course, opens in the right atrium, where we talked about Thebesius or Thebesian valve. This is also the venous drainage of the right atrium. Here you can find the opening of the coronary sinus. It is between the this triangle, which is, there is no time to talk about it now, but between the Eustachian valve and the entrance of the right ventricle, which is the atrioventricular orifice. Somewhere between these two structures here is the opening of the coronary sinus. So the venous drainage of the heart has been also explained to you. Great cardiac vein, small cardiac and middle cardiac veins. We almost finished talking about the blood supply of the heart. Here you can see an occlusion in the coronary arteries and their branches. Here after, of course, embedding, I think, angioplasty with a balloon that makes the diameter and of course the blood supply, the blood flow here. Look, here it is occluded, here it is back to normal. This is 1, 2, 3 are the most common areas where the occlusion takes place. Now, the most common one, as we mentioned, it's the LAD. The second one is the right coronary artery. The third one is the circumflex. In former slides we just mentioned that it's the left, it's the LAD, and 50% it's 20% or 30 the circumflex, and in 20% the right coronary artery. It's a variable among different populations, and this should not confuse you, as I'm not asking about the numbers. I will just ask about the most common artery that gets affected, which is the anterior interventricular or LAD, and of course circumflex and the coronary artery. You need to appreciate all this as we proceed. Now, if an occlusion does take place and you need to solve this problem, before this operation here, usually we were making bypass. Suppose the occlusion is here, we were just taking veins and we would pass this occlusion here. Nowadays we don't do this. Instead we take, as you can see, the great saphenous vein. We take it from one leg or two legs. The surgeon evaluates the structure and the shape of the valves of the great saphenous vein, and then they choose segments, and they don't do this anymore. They just embed, they just make a hole in the ascending aorta, because this part of the aorta is within the pericardium. So they have the same source as the coronary arteries. So why going this whole area here? They would just put the newly harvested vein from the leg into the ascending, and they would take it and put it in front, distal to the occlusion. So the blood supply would be again normal, and we can use up to 3-4 arteries in the same operation. Some patients, they come with horrible occlusions everywhere in the heart and cabbage. This operation can help them to maintain a normal life style. Now, looking at the ECG and its findings can be reflected on the source of the occlusion, which artery is to blame. So you are evaluating the ECG, okay, and you become an expert in ECG. You need just to know, before you go and make cath for the patient, you just need to know which artery is most likely occluded, and you can see this as the changes telling you on the ECG. So there is an association between them, but also it's not something I would ask about in this course. Of course, you need more to practice more to be able to judge on this.